Good morning, everyone. Welcome to our third live session of the day. Today, we are so very thankful to have Dr. Dorette Noorhasan with CCRM, which is at Dallas Fort Worth location, excuse me. Dr. Noorhasan is the medical director and co-founder of CCRM Dallas Fort Worth. She's a board certified in reproductive endocrinology and infertility. And her resume, honestly, it goes on and on and on, and we'd be here for another 10 minutes. So if you'd like to learn her full background, you can go to her profile in the speaker section. But I'm going to let the doctor take the floor, and she's going to leave some time at the end for questions. So I do ask that you hold your questions until the end. So, Doctor.
Thank you so much for that very kind introduction. I'm Dorette Noorhasan, the medical director at CCRM Dallas Fort Worth, and today I'm going to give to you a basic talk on Fertility 101. So my goals today are to disclose a little bit about myself and my practice, but then we're going to get right to the meat and potatoes. That is defining infertility, talking about some very basic evaluation and overview of treatment options. At the very end, we'll discuss or I will answer your questions. So a little bit about myself. The reality is I've stood in the shoes of each and every one of you listening today. I met my husband much later in my reproductive years, and we had troubles getting pregnant. It took me 5 rounds of IVF, that is 5 rounds of about 5 injections a day in my case, and 5 egg retrievals. We did pre-implantation genetic testing, aneuploidy screening, that is testing the embryos for aneuploidy that can lead to miscarriage or failed implantation. But out of those 5 cycles, we got a total of 1 euploid embryo, so 1 embryo with the correct chromosomes or gene regions. And that embryo was transferred to a surrogate. So it is because of another woman's kindness that I'm a mother today. But I understand exactly what you're going through, that roller coaster of getting your hopes up, thinking that this is a cycle that's going to work, and then only to realize you're back to square one a couple weeks later. And the most difficult aspect is figuring out how to pick yourself back up and do yet another cycle. So my husband and I, we had explored donor egg, donor sperm. We got lucky in that we were able to get a biological child. We did egg freezing, sperm freezing, surrogacy, PGTA testing. So I've totally gone through every single thing that you are going through right now. A little bit about my practice. I'm part of the CCRM network. We are a network of fertility clinics. There are 10 locations in the country, and then the 11th is in Toronto. We are actually the newest of those 11 locations in Dallas Fort Worth. We are conveniently located off of many expressways, and it's only about a 30-minute ride to the airport. We're a center for excellence with multiple insurance carriers, which makes it easier for patients because the insurance carriers see us as a tier 1. There are now over 40 physicians in the CCRM network. So one of the big questions I get is, can I become a parent? And the reality is, in the 21st century in the United States of America, becoming a parent is truly a real possibility. So what exactly is infertility? Infertility is defined as in a couple where the female partner is under age 35 and they've been trying for a year or longer to get pregnant without success. Now, if that female partner is age 35 and older, they've been trying for 6 months or longer to get pregnant without success, they also meet the criteria for infertility. So why drop the trying to conceive from 12 months to 6 months starting at age 35? Well, age 35 is advanced reproductive age or advanced maternal age. We tend to see more abnormal embryos and higher chances of infertility and higher chances of pregnancy loss starting at age 35. So it means that we should start becoming more aggressive around that age. In addition to patients that meet this criteria for infertility, I see many other patients. I see patients who are electively trying to freeze eggs, freeze sperm, freeze embryos. I see patients who are members of the LGBTQ population, members who will need donor egg, donor sperm, or surrogacy, as in my case, surrogacy. And so we are able to help many people. You don't have to wait 6 months to a year to try to get pregnant. There are some patients that meet criteria for infertility from the very beginning and will want to see a fertility specialist. What are the causes of infertility? Well, the truth is, when we do find a cause of infertility, about half the time it's related to the female, and the other half of the time it's related to the male. So in this diagram, we have about 33% female, 33% male. The other 33%, about 20%, is unexplained infertility. So unexplained infertility means that the couple has done all the testing and all the testing is normal, and yet they're still not getting pregnant. The good news is these couples with unexplained infertility do go on to have successful pregnancies. And the other 13% here is related to causes in both the male and female as the source of infertility. So when a couple presents to me, there are three big categories that I want to explore. So I do testing to evaluate the eggs in terms of their quantity and quality and whether or not the woman's ovulating. I do testing to evaluate the sperm in terms of quantity and quality. And in quality, we're looking at motility, so how fast does the sperm move, and morphology, the shape of the sperm. The shape of the sperm can affect its ability to fertilize the egg. And the third category we look at is the reproductive tract. Are the fallopian tubes open? Is the uterus a normal environment for an embryo to implant and grow? So eggs. It's true, women, we're born with all the eggs we will ever have, and we lose them very quickly with time. And so when we're about 4 to 5 months pregnant, or 4 to 5 months gestation in our mother's uterus, so we're actually the fetus in our mom's uterus, we have about 6 to 7 million eggs. By the time we're born, that number is already down to 1 to 2 million. By the time we hit puberty and hit our first period, we're working with 300 to 500,000. And we're going to use that 300 to 500,000 over our reproductive years. So by the time we get to menopause, it's less than 1,000. However, it's not just egg quantity that declines with time. Egg quality also declines with time. So there are many aspects that I look at in terms of egg quality and an egg reserve. So we talked about age 35 and older earlier on. There's testing that I do typically in the second, third, or fourth day of the menstrual cycle. And these are hormone testing. So we're looking at an FSH. FSH means follicular stimulating hormone. Typically, if that hormone value is greater than 10, and a concurrent estradiol level that's been drawn that same day is under 80. And I'm pretty lenient with under 80. Some clinics are very strict. They want that estradiol level under 68. But if you have a low estradiol level and your FSH value is higher than 10, that suggests a low egg reserve. AFC, antral follicle count, that is the number of small follicles we see in the ovaries at the time of an ultrasound. We're looking for antral follicle count about 10. Numbers under 10 suggest to us a low egg reserve. AMH, anti-Müllerian hormone, a value under 1 suggests a low egg reserve. Now, again, I'm pretty lenient with my numbers. Some clinics are very strict. Some clinics use 1.3 or 1.5 as their cutoff. I'm giving everyone the benefit of the doubt by using a value under 1. Other things that suggest a low egg reserve: poor response to gonadotropins, meaning that they're taking injectable medications to help their ovaries produce the eggs, but they're not having a good response. We're going higher and higher in the dose just to get a very minimal response. Smoking. Smoking will decrease our egg reserve. Smoking adds 2 to 4 years to our ovaries. So for example, if you're 35 as a chronological age, your ovarian age is actually 37 through 39. And a lot of that has to do with how much do you smoke and for how long you've been smoking. And believe it or not, secondhand smoking is just as bad as smoking yourself. So try to avoid secondhand smoking. There are some of my patients that unfortunately have premature ovarian failure. They're going through menopause in their 20s, and that suggests a low egg reserve. Other items that suggest a low egg reserve: previous ovarian surgery, chemotherapy and radiation in my cancer patients, And then endometriosis. Endometriosis is an inflammatory disorder that can affect the fallopian tubes due to scar tissue, but it can also affect the ovaries in terms of it causes a lot of inflammation in the ovaries. You can have large ovarian cysts called endometriomas. All of those can lead to an inflammatory condition in the ovaries and therefore a low egg reserve. What I want you to get from all of this is a big picture, meaning that there's not one specific criteria that says there's low egg reserve in terms of quantity and quality, but you really want to look at multiple testing of the eggs, and that overall will add up to the big picture as to egg quantity and quality. I really like this diagram. This is an old study from 2004, but it shows age and FSH as independent predictors of IVF pregnancy success rate. So here you have age, increasing age on the x-axis, and higher or increasing IVF pregnancy rates on the y-axis. And remember how we talked about FSH values under 10 being the most ideal. So you have FSH under 10, FSH 10 to 15, 16 to 20, and greater than 20. So here, let's look at age first. So you see with increasing age, no matter which category of FSH you're in, IVF pregnancy success rates decline with age. Now, if we keep age consistent and just look at FSH, so if you look at an FSH value under 35, women with lower FSH values did better than women with higher and higher FSH values. Now, this is an old study from 2004 where IVF pregnancy success rates were 35, 40%. Today, with PGTA testing, IVF pregnancy success rates can be as high as 60+%. So just keep that in mind. Ovulation. There are some things that give me an idea if a woman's ovulating regularly. If a woman says to me, I have very regular cycles every 28 to 30 days, like clockwork, there's a good chance she's probably ovulating. She can do basal body temperature charts. And so the basal body temperature charts, you see this biphasic temperature. So prior to ovulation, the temperature is lower. Then after ovulation, the temperature is about a degree higher. Ovulation predictor kits. There are multiple commercial kits now available that you can buy over the counter where you can check your first morning's urine to see if you're ovulating. And now there are kits available where we can check your progesterone as well to see if you're ovulating. So that's the pregnadiol glucuronide testing. That's also called the PROVE test, and that's available. You can buy that without a doctor's prescription, and that tells us if you've recently ovulated. You can also go to your doctor's office and get a mid-luteal progesterone blood test as well to see if you ovulated. There's some women that have polycystic ovarian syndrome. And so polycystic ovarian syndrome, you would have to meet 2 out of the following 3 criteria: irregular cycles, clinical and or laboratory evidence of increased androgens. So some women complain of excessive hair on their face or their midline on their belly button, from their belly button down. You would see on a blood test mildly elevated levels of testosterone, not to the range that men are in, but just mildly elevated. And then we would see polycystic ovaries on sonogram. So if a woman meets 2 out of these 3 criteria and have been ruled out for other forms of infertility or irregular cycles, chances are she probably has PCOS. Now we've talked a little bit about eggs. Let's talk about sperm. So unlike women who are born with all the eggs they will ever have, men get to make new sperm every day for the rest of their lives. We all hear those stories of the 70-something-year-old man who's married to the 20-something-year-old woman, and they're getting pregnant very easily. There is some decline, though, in men in terms of quantity and quality of sperm. Now, so once a sperm is made, the lifespan of a sperm is about 74 days. So typically the sperm you see today in a specimen that we see in our lab today in a specimen, that sperm was made about 2.5, 3 months ago. When we get a specimen, we analyze it. So we do a semen analysis. We're looking for several parameters. The key ones that I look at are volume. So I'm looking for a volume anywhere between 1.5 to 5 ml. I want to see a concentration or quantity or count of the sperm, about 15 million per ml or higher. And then a motility of 40% or higher, so how fast the sperm is moving. And then the morphology or shape of the sperm, I'd like to see about 4% or higher. And that usually indicates that this is a very good semen analysis. There are causes of low sperm quantity and quality. So one is very poor production, someone with testicular failure or going through some type of menopause related to, or for men essentially, blockage, history of a vasectomy. So vasectomy is also a blockage where part of the vas deferens is snipped. Congenital bilateral absence of the vas deferens. Those men can also present with essentially little to no sperm in the sample. Retrograde ejaculation, so that is instead of the sperm being produced in a cup, many times the sample is backed up into the bladder and is in the urine. You tend to see these in men with very poorly controlled diabetes. Varicoceles are dilated veins near the testicles. And these are actually quite common, varicoceles. Most of them do not need surgical treatment. In the very, very severe cases, surgical treatment can improve sperm quantity and quality. But the reason for the varicoceles, or the thought process behind of it, so women, our ovaries are inside our abdominal cavity. Our ovaries can tolerate high temperatures like body temperature. Men, the testicles hang outside the abdominal cavity. And the reason is sperm needs a cooler environment for the sperm to grow and be functional. Now, when you have large dilated veins surrounding the testicles, then the warm blood in those veins are next to the testicles, and therefore they're now exposed to a warmer environment, and therefore that can potentially affect the sperm quantity and quality. Men who use steroids, so the bodybuilders, men on testosterone, we see so many of these testosterone clinics now popping up. Testosterone's a fantastic drug. It makes you feel better about yourself. You lose weight. You have higher lean body mass. Libido is improved. Men feel very good on testosterone. It's not good, though, if they want to have a baby. And same thing, men who utilize steroids for bodybuilding will also have low sperm quantity and quality. And then for my cancer patients who are undergoing chemotherapy, that can affect the sperm quantity and quality. So we've talked about eggs, sperm. We're going to talk about reproductive tract now. And so this is a general diagram to show you what the reproductive tract looks like. Here's the vagina. The opening to the uterus is called the cervix. And then here's the uterus. Typically an embryo implants and grows here. The ovaries are attached to the uterus, and then the fallopian tubes are connected directly to the uterus. So typically a woman ovulates, the finger-like projections on the fallopian tube grabs the eggs when the woman ovulates. The egg starts to head down towards the uterus. At the same time, sperm is deposited in the vagina, the sperm swims up, and then the egg and sperm typically meet each other in the fallopian tube. And now fertilization can occur, and it's called an embryo. The embryo will migrate down and implant in the uterus. So let's look at some testing of the female reproductive tract. One of the tests that can be done is a histosalpingogram, HSG. That's an X-ray test where X-rays are run in the background. And then we inject dye from below. The dye fills the uterus in this beautiful triangular structure. That's the uterus. And here you can see the dye going into the right tube. And all the scattered stuff here means that the right tube's open. Here you can see the dye going into the left tube, and all that scattered stuff here means the left tube's open. So this is a normal histosalpingogram. Another test to evaluate the reproductive system is a saline infusion sonogram, sometimes called a hysterosonogram or sonohistogram. So it's a vaginal sonogram, but as we're doing the vaginal sonogram, we're going to inject saline into the uterus. Now, I use a 3D machine. This is actually a 2D image that I have up here, but I use a 3D machine which actually rebuilds the uterus, and I can see it quite well and looking for abnormalities. But as the saline comes in, you see the cavity, and the cavity is filled with the dark fluid. So when it's filled with the dark fluid, that means it's a normal cavity. These white dots here are just bubbles from injecting. But if you see large masses inside the cavity, like polyps or fibroids, that usually indicates an abnormal saline infusion sonogram. A third method to evaluate the uterine cavity is a hysteroscopy. There are diagnostic ones that can be done in the office, and then operative ones that are done in the operating room, where polyps can be removed, fibroids can be removed, septums can be fixed, scar tissue can be taken down. So this is what a normal cavity looks like on a hysteroscopy. So a hysteroscope is a small telescope that goes directly into the uterus, and we're looking with our eyes inside the uterus to see what the uterus looks like inside. So we've done a thorough review of eggs, sperm, and the reproductive tract. Let's move on to treatment. There are various treatment options. The first one is ovulation induction, so taking medications to induce ovulation or produce the eggs. These medications can be pills, things like clomiphene citrate or letrozole, or gonadotropins. Gonadotropins are versions or liquid versions of FSH and LH, which are hormones that are used to induce the ovaries to make eggs. So you can combine ovulation induction with either pills or injections with an intrauterine insemination. So an insemination means putting the sperm directly into the uterus. You could also do ovulation induction with timed intercourse. We see about a 2 to 3% higher pregnancy success rate with insemination than just timed intercourse. So many patients will choose to do insemination. And then in vitro fertilization. In vitro fertilization means the woman takes injectable medications to produce the eggs. The eggs are then retrieved vaginally. She receives anesthesia for that procedure. The eggs are fertilized with the sperm in the lab to create the embryos. The embryos will grow in the incubator for 5 to 7 days until it's at the blastocyst stage. If a woman chooses to, she can choose to do pre-implantation genetic testing of her embryos. So pre-implantation genetic testing means taking small snippets or a biopsy off the trophectoderm. So the trophectoderm are cells that will eventually become the placenta. Typically, we take 3 to 5 cells off of that. And typically, the trophectoderm and the embryo share the same genetic makeup. So we can test the trophectoderm for a generalized aneuploidy screen. A generalized aneuploidy screen means testing for things like Down syndrome, Turner syndrome, trisomy 16, trisomy 18, monosomy X, genetic causes that can lead to miscarriage or failed implantation. So an aneuploid embryo has an abnormal chromosome makeup or gene regions, and therefore less likely to implant and more likely to result in a miscarriage. Whereas a euploid embryo has the correct number of chromosomes or gene regions, and therefore more likely to implant and more likely to result in a live birth. We can also do PGTM, pre-implantation genetic testing, monogenic. So, for example, that depends on a specific couple. So, couple of examples. If a woman and a man, if they both are carriers for the cystic fibrosis gene, if you're a carrier for this gene, nothing bad happens to you, but it's only if you have the disease. But if a child inherits one copy of that gene from the mother and one copy from the father, and now has 2 copies of the gene, that child can actually have the full-blown disease, which is actually a disease with very high morbidity and mortality. And so we can do PGTM and figure out which embryos could potentially have the disease, and do not transfer those and transfer either ones that completely don't carry the gene or are just carriers, but do not have the disease. Another very common one that I see is BRCA. So BRCA, the BRCA gene, codes for potentially having ovarian or breast cancer. So it really does increase your risk for ovarian or breast cancer. With the BRCA gene, what if you wanted to eliminate that BRCA gene being passed on to the next generation, we can test the embryos as well for the BRCA gene. Intrauterine insemination. So we get the sperm, we wash it, we spin it down, we aspirate the sperm sample into a pipelle, and this is just like a pap smear. Speculum exam, the syringe and the catheter. The catheter goes directly into the uterus. All the sperm is deposited into the uterus, and we remove the speculum. Super easy, just like a pap smear. I like this diagram a lot because this is a good overview of what IVF is, all in one picture. So the woman takes injectable medications to make her ovaries produce the eggs. She undergoes the egg retrieval. It's done under ultrasound guidance. The needle goes into the ovaries, aspirates the fluid in the follicles. The fluid is collected in a tube and given to the embryologist. Now, we cannot see the eggs with our eyes, so the embryologist, he'll pour the eggs or the fluid into a petri dish and look under the microscope, pull out the eggs. That same day, the husband gives us a sperm sample. We fertilize the eggs with the sperm to create the embryos. The embryos will grow in an incubator for up to 7 days. At the blastocyst stage, we can biopsy them for the PGT testing, and typically we'll freeze the embryos. Once we have PGT results, the woman then takes medications to prep her uterus. Once the uterus is ready, we inject or put the embryo directly into the uterus, all done under ultrasound guidance. Third-party reproduction. We help members of the LGBTQ population have children as well, and typically they'll need donor egg, donor sperm, and or surrogacy. And like I mentioned earlier on, my husband and I, we ended up using surrogacy, but we started to explore donor egg and donor sperm, so it's something I'm quite familiar with as well. I really enjoy giving educational videos and posts about fertility. Please feel free to reach out to me on social media, and thank you for your time. I see there may be some questions coming in here, so let me look at the questions. For a did you say it tests for if ovulation occur, meaning if doing at-home insemination and using this test, would it, okay, I got what this person's saying. So they're asking me about the PROVE test. So PROVE test can test if you ovulated recently, and yes. So you would take the test about a week after a theoretical ovulation, and that shows that you ovulated the previous week. Is there any REs at your clinic that specializes in DOR? Well, DOR is our big specialty, so I see a lot of DOR. That's pretty much a lot of what I see is diminished ovarian reserve, and it's quite a bit of what we see at CCRM. We are known for our IVF lab pregnancy success rates, and because of our IVF lab pregnancy success rates, we tend to see some very difficult cases, including women with DOR. Seems like those are all the questions for now. Are there any other questions?
I have a quick question in regards to Clomid. Would you start a woman who was in her early to mid 40s on Clomid, or would you recommend that she would go straight to IVF?
That's an excellent question. So first of all, we're all very different. So 35 is the average age for advanced reproductive age, and we tend to be more aggressive with treatment at that point in time. But one of the other things, but there are other women who have fantastic egg reserve and could potentially do fine with Clomid in their 40s. The majority of patients, though, their egg reserve starts to decline significantly at 35. So at 35% of women's eggs and therefore her embryos are abnormal. At 38, it's about 50% of her eggs and embryos are abnormal. At 40, 65% of her eggs and embryos are abnormal. By the time you get to 42, 43, it's 90+% of her eggs and embryos are abnormal. In women in their early 40s, definitely I would suggest being aggressive fairly quickly, doing IVF with PGT testing, PGTA, just because you have so many abnormal embryos at this stage. That's going to really increase your odds of having a healthy pregnancy and getting to a live birth in a faster way. Oh, someone just asked me a question about can they go to their OBGYN or go to a specialist for testing? I think either would be fine. If your OBGYN is comfortable doing the testing, you can certainly go to your OBGYN to start the testing. If you want to start directly with a fertility clinic, that's also very reasonable to start with a fertility clinic for testing.
I have a question. I was just wondering if you have ever seen a IVF success from a frozen sperm sample. I guess you probably have, but in your experience, are the likelihood and the chances any worse from frozen sperm compared to fresh sperm?
Very good question. So frozen sperm versus fresh sperm. A lot of it has to do with the sperm at the time of the freezing. So for example, donor sperm, it's all frozen, but donor sperm is fantastic. It's good sperm going into the freezing process and you get good sperm coming out of it. The more abnormal the semen parameters are of the sperm going into the freezing process, the less likely that sperm will do in the thaw process when it's thawing for fertilization. So with donor sperm, for example, even with donor sperm, which has normal parameters and all normal semen parameters, only about 50% of those sperm survive the freeze thaw. And that's a normal freeze thaw survival rate for sperm. But if you have a sperm with more abnormal parameters going into the freezing process, your survival rate for the sperm coming out of that freezing process will be lower. And a lot of it really has more to do with the sperm sample that was frozen and not so much the actual vitrification process itself or the freezing process itself. Looks like someone just sent me a message about thyroid. Thyroid, absolutely, thyroid can affect your fertility. And so getting healthy prior to pregnancy is very important. So if you have hypo or hyperthyroidism, you certainly want those controlled first before you start fertility treatment. If you have high blood pressure, you want to be on blood pressure medicines that can control your blood pressure before starting fertility treatments. There are blood pressure medicines that are safe in pregnancy that you can get started on before trying to get pregnant. So you want your blood pressure stabilized. If you have diabetes, you want your diabetes under control before you try to get pregnant as well. So whatever your medical diagnosis is, you want those things well taken care of before you get pregnant. Are there any other questions? Did I miss any other questions?
I have a quick question. Hello.
Hi.
So hi, a little bit of background. So I had one chemical pregnancy and then 2 miscarriages at 7 weeks. Before the third one happened, went to a reproductive endocrinologist. He said that I have a hormonal imbalance. My prolactin is a little bit elevated, but progesterone was slightly low. So he suggested bromocriptine, and he also suggested Clomid. And I asked why Clomid if we are gonna fix prolactin this way with bromocriptine. So he said, I feel like you need both. So I wanted to try just bromocriptine. So I got pregnant on the first cycle. It ended up with a miscarriage, and we tested the embryo. It was a chromosomal trisomy 16. So now I'm trying again for 5 months on bromocriptine with no luck. So I'm starting exploring like other options. Maybe I should try Clomid. So my question is it reasonable to try Clomid or incorporating other things? Thank you.
No, not a problem. So let me clarify. You've had 1 baby and then 2 miscarriages. Is that correct?
I had 1 chemical pregnancy. Okay, and then 2 miscarriages at 7 weeks.
Got it. And how old are you?
30.
30?
30 years old. Yes, 30 years old. My period was regular. I never envisioned this for myself. I thought I was going to have like high chances of conceiving. And here I am.
So I would first start with, you may need a little bit more testing. So I'm glad your prolactin is under control now with the bromocriptine. And so that goes back to getting all medical diagnoses under control first before pursuing fertility treatments. But now that you've had, so recurrent pregnancy loss, some people say 3 or more losses. We actually start testing at 2 or more losses. So I think you, first of all, will need a recurrent pregnancy loss evaluation to see why you're losing the pregnancies. And they may find a reason for you losing the pregnancies. You did mention that the last one was a trisomy, and maybe IVF with PGTA testing may be beneficial in this scenario. I have some patients, and there's some, it's not everyone, that are in their early 30s, but they have a large number of aneuploid embryos, and that's the reason they're having miscarriages. So that may be something to look into, is to ask your doctor for a recurrent pregnancy loss evaluation. And then think about.
Yeah, sorry to interrupt, but we've already done like most of the testing, like clotting, karyotyping, other hormones. So basically everything you can think of probably. And my doctor's advice was just to keep trying until we get lucky. Or because he was not willing to do IVF because his clinic is not doing IVF for people who can get pregnant. But again, my question was like, should I explore Clomid just to increase my chances of getting pregnant faster? And I don't know what to do.
I'm sorry that's happening to you. So Clomid could increase your chances of getting pregnant faster, but it doesn't help on the pregnancy loss side. And that's where IVF with the PGTA testing will be beneficial, because you really want to know that you're putting in a euploid embryo.
Yes, thank you. And would, like, for example, your clinic take me? Because my doctor is saying I'm in Tennessee, in Knoxville. They're saying that they cannot take me because I can get pregnant.
Oh, I have tons of patients coming from Tennessee to see us. Quite a few patients. So absolutely, you're more than welcome to come and see us. DFW is International Airport it's about 30-minute drive from our office, and I see patients from all over the country and a few from all over the world here. And I have quite a few patients coming from Tennessee to see us. So yes, we will certainly see you.
Thank you so much.
You're welcome. And then looks like there's a couple more questions. Is there a way to improve your lining and prevent implantation failure? So if your lining is too thin, I'm assuming that's what this person's asking. If your lining is too thin, there are multiple ways to do the estrogen. So you can do it intramuscular, vaginal, oral, transdermal. We can use vaginal Viagra. There are quite a few different ways to improve the lining. If you have not had a hysteroscopy, you may need a hysteroscopy to look for to look and see if you have any scar tissue in the uterus. But those are typically many of the ways that a doctor will tackle poor lining. Let me see. There's another question here. So someone's asking me if their husband's sperm has 0% motility, will IVF be successful? And yes, IVF can be successful even with sperm samples with 0% motility. We have IVF pregnancy success rates from TESI samples, meaning we get the sperm directly from the testicles, and those have 0% motility. So yes, IVF can be beneficial for you as well with 0% motility. Okay, someone asked me a question about maca versus DHEA. So I think improving your health is important, and taking vitamin supplements, including high-dose antioxidants, is very, very important to improve egg quality and quite significantly. And I educate all my patients about healthy lifestyle, eating really, really healthy. There is a lot to say about what we take into our bodies is what we get out, in terms of the way you feel about yourselves, in terms of your hair, your skin cells, but also on the inside in terms of your egg cells. So this person's asking me about maca versus DHEA. I like DHEA more. So it's about 25 milligrams 3 times a day is the dosing for DHEA. And that's what I tend to use over the maca. But I have a ton of my patients on high dose antioxidants prior to starting IVF, and they stay on it until they start the gonadotropins or injections for IVF, and then I pull them off those high dose antioxidants. And the reason is, many of the herbal things, I have patients who go and see the acupuncturist and they're in Chinese herbs, which I'm fine with. I'm fine with any of the over-the-counter herbal stuff. As long as you improve your health, take high-dose antioxidants, eat right, and take really, really good care for yourself. As long as you stop those extra vitamins when you start the injections for IVF, that's fine. And the reason is, some of the herbal stuff has estrogenic and anti-estrogenic properties. So they can have a negative impact on your IVF. And some of the vitamins, including the vitamins that are on my vitamin list, improve blood flow to your organs, like to your ovaries and to your uterus, but then it can predispose you to bleeding excessively at the retrieval. So I usually have you stop it when you start the injections. That gives you about a week and a half to get it out of your system. I think those are all the questions. They haven't cut me off as yet. I know I'm well over the time limit. I'm
You
assuming
have so many great questions, and I didn't want to stop you. So we extended it a little bit for you guys because these are all such great questions. We have 3 more minutes. So if there's any other questions, well, maybe 2 more questions, then then we can wrap it up.
Perfect. Thank you.
Sure.
All right, so if there's no more questions, then thank you so much, everyone, for listening and for spending some time with me on a Saturday morning.
Great. Thank you so much, Dr. Noorhasan, and thank you, everyone, for joining us today. Enjoy the rest of your day.
Bye, y'all. Bye.